So I won't repeat the very long title, and I'll immediately go to the background of this study. I think it's important that you're all kind of aware of the background of this study because it really explains why we did it. As we all know, prostate cancer is one of the most common cancers for men, and in westernized countries we can even say that about a quarter of all new cases diagnosed for men are prostate cancer. A prostate cancer tumor grows in an environment of testosterone, and so therefore one of the very common treatments for metastatic and locally advanced prostate cancer is endocrine treatment, because what this treatment does is it's basically going to block the production of testosterone. It's going to either interrupt the production of testosterone, or it's going to make sure that testosterone cannot go to the prostate. And so because then there is a lower circulating level of testosterone, the prostate tumor will grow more slowly or will even shrink. So there are different types of endocrine treatment, and that basically that means that they have a different way of interrupting this testosterone. It's important that you know the difference because when I get to the findings, I will come back to this. So, for example, anti-androgens, these block the access to the prostate, meaning that there is still testosterone circulating in the body, but it cannot get to the prostate. Whereas the GnRH agonists and orchiectomy basically means that you're going to interrupt the production of testosterone, and there's almost no circulating level of testosterone. And so this treatment has been common for the last decade, and a lot of side effects have been reported, mostly linked to metabolic changes like hot flushes, but more recently one started to focus on heart disease. There are there are a couple studies out looking at ischemic heart disease and mainly focusing on GnRH agonists as endocrine treatment for prostate cancer. And so what we try to do in our study is basically look at different types of endocrine treatment, but also at different types of heart disease. So not just ischemic heart disease and GnRH agonists. And so what population did we use for this? We used PC-Base Sweden, which is a database containing about 80,000 men with prostate cancer in Sweden from 1997 until 2007. It's based on the National Prostate Cancer Registry in Sweden, and it can be linked to all other national registries in Sweden. And so the heart diseases that we were interested in was, of course, ischemic heart disease, myocardial infarction, but also arrhythmia and heart failure. And what kind of method did we use to then look at whether the patients, prostate cancer patients with endocrine treatment are at higher risk for these heart diseases? We actually use a method called standardized incidence ratios or standardized mortality ratios. So basically what it does is you're going to compare the number of events of heart disease in your prostate cancer group, and you're going to compare it to the numbers you observe in the total Swedish population. And while doing that, we took into account their age, the calendar time, and also their history of heart disease. And so from these 80,000 men in PC-Base Sweden, we took about 30,000 men, all those who got endocrine treatment as their primary treatment. And so if we then look at the different types of heart disease, and we have SIRs, which refers to incidence, and SMRs, which refers to mortality, we can see that all our estimates are larger than 1, meaning that there is an increased risk. And then I'm not going to go into detail for the other findings, but I'll briefly summarize them for you. So the one finding is that for each heart disease, as you could see in the previous slide, we saw an increased risk for mortality and incidence. And then, but that was in the total group that got endocrine treatment. And then, as I said, we wanted to look at different types of endocrine treatment. And we saw that it was increased for every type of endocrine treatment, but the increase was the least for those getting anti-androgens. And then the last thing we did is we split up our prostate cancer patients in those with a history of heart disease when they got diagnosed and those who did not have a history of heart disease when they got diagnosed with prostate cancer. And we saw that, again, for both groups, there was an increase in risk for heart disease, but it was less pronounced for those who already had a history of heart disease. So what can we get from all these findings? It's a large observational study, and so we cannot come up with direct causal explanations, but it really shows that it is important to take heart disease into account when before starting a prostate cancer patient on endocrine treatment, especially since endocrine treatment is these days not only used for metastatic prostate cancer patients, but more and more also patients with less severe disease start to get this treatment. Another thing that we got from our findings is because we saw that the risk was less increased for those treated with antiandrogens, that might support a hypothesis that testosterone is protective for the heart. So if you recall what I said in the beginning, when you give antiandrogens, the difference with the other treatments is that there is still circulating testosterone in the body. And in the other ones, there is no testosterone, almost no testosterone circulating. So it can be that the risk for antiandrogens is less severe than for the other treatments because there is still circulating testosterone. Obviously, based from these findings, it shows that there is also a need for more studies, especially also experimental studies, looking at the underlying biological mechanisms, such as this hypothesis on the protective effect of testosterone on the normal function of the heart. And then in the future, when there are other treatments than hormonal treatment for this metastatic prostate cancer patients, one could compare hormonal treatment versus the new treatment and see whether this increase is really only due to endocrine treatment and not a combination of prostate cancer and the endocrine treatment. Thank you very much.